Hello, good evening. Thank you for joining us again. This is a series of webinars on updates on glycemic control biomarkers in diabetes. This is an educational opportunity organized by the Emory Diabetes Training Academy under an educational grant by EKF to Emory University. Thank you so much for joining us and be on the audience for all these lectures. We have so far 3 lectures. We have 3 more lectures. Today I have a great pleasure to have a nephrologist as a faculty. So far we had endocrinologists, diabetologists, epidemiologists. Today we have a nephrologist. So he's our great collaborator, Dr. Barry Freedman, who is the John Feltz Professor of Medicine and Chief of Endocrinology at Wake Forest School of Medicine. He's also the Chief Medical Officer for Health Management System, which is a center of dialysis. So a very well-known expert on the topic. Dr. Freedman will be discussing today the role of glycated albumin in patients on dialysis. Thank you again, Dr. Freedman, for agreeing to participate and to be with us today. And thank you for the audience to join us. Thank you and welcome.
I'd like to thank you for inviting me to participate in the Emory Diabetes Training Academy. And as Dr. Galindo said, we'll be talking about glycemic control biomarkers in patients with diabetes, and particularly role of glycated albumin in patients on dialysis. Here's my disclosure slides. I have research support from the NIH, AstraZeneca, Renalytix AI, and I'm a consultant for AstraZeneca and Renalytix AI. And I've done prior investigator-initiated research with Asahi Kasei Pharma Corporation, who make the GA assay. In my mind, as a nephrologist, the current limitations with our assays of diabetes control center around the fact that we have to assess blood sugar control in patients on dialysis and with advanced chronic kidney disease, and it's very complex due to changing glucose homeostasis, potential effects of glycemia, and altered pharmacokinetics of diabetes medications just related to kidney disease. So we all believe that glycemic control is important in outcomes. The ideal assay in patients with advanced nephropathy should predict cardiovascular disease events, patient survival, risk for hospitalization. We need a test that the higher the blood sugars are, the worse the outcomes are. And although hemoglobin A1C has been the gold standard in patients with normal kidney function, its predictive value is very uncertain in patients with end-stage kidney disease or severe kidney disease with an estimated glomerular filtration rate less than 30 milliliters per minute per 1.73 meters squared. You all know that hemoglobin interacts with glucose to form A1C, and hemoglobin is located inside red cells. That in and of itself is the problem in end-stage kidney disease. There's shortened red cell survival, not allowing enough time for glucose and hemoglobin to interact. There's erythropoietin deficiency because it's made by the kidney, and there's erythropoietin resistance. There's blood loss. Patients lose blood in the dialyzer circuit on hemodialysis, frequent lab drawing, and there's often a requirement for blood transfusion, all of which have profound effects on hemoglobin A1C. The glycated albumin assay is another glycated protein, and it's useful for following recent glycemic control in the past 2 to 4 weeks, as I'll show you. It much more rapidly reflects the status of blood glucose control than hemoglobin A1C, and although there's a potential for falsely low readings in patients on peritoneal dialysis who have dialysate protein losses and hypoalbuminemia, in fact, we have done studies in peritoneal dialysis and found those are mostly theoretical concerns, and actually the assay is quite predictive. Another glycated protein that may be useful in kidney disease is fructosamine, that measures ketoamines formed by non-enzymatic glycation of serum protein. It's useful for glycemic control over the past 2 to 4 weeks. And again, there can be falsely low readings in patients on peritoneal dialysis who have protein loss in the dialysate, hypoalbuminemia due to protein energy wasting, and paraproteinemia can confound this assay. There was a study, the CHOICE study, which looked at 503 new hemodialysis patients, and it showed that a doubling of either fructosamine or glycated albumin reflected a 2-fold increase in all-cause mortality and cardiovascular mortality. So there's long been a sense that these other assays of glycemic control beyond A1C in patients with severe nephropathy may be more predictive. This slide is just meant to show you that, the glycated albumin and the fructosamine have 50% of their power in the first 2 to 3 weeks, 17 days. The full effect, the next 50% comes out at about 2 months of glycemic control. The hemoglobin A1C we know is spread out over 4 months, and most of the effect is seen within 1 month. So the glycated albumin is a more recent picture than the hemoglobin A1C, as is fructosamine. This is a meta-analysis that I'm sure many of the other speakers have focused on, looking at serum glycated albumin predicting all-cause mortality in dialysis patients with diabetes. This study had about almost 26,000 patients in it. And I'm pleased to show you that one of our reports was included in this meta-analysis, and I will take you through this study. And long story short, the higher the glycated albumin, it was associated with all-cause mortality in patients on dialysis. So it bore out its promise. This is effects of glycated albumin on cardiovascular mortality. And again, you see a strong trend, just missing statistical significance in this almost 26,000 patients. An effect of glycated albumin on cardiovascular events, again, a strong trend, just missing statistical significance felt to be due to underpowered in this 26,000 person meta-analysis. But what opened my eyes to this field way back in 2007 was what I consider the seminal report by Inaba and his group in Japan. And Inaba reported the effects of glycated albumin versus hemoglobin A1C in 538 patients with type 2 diabetes mellitus on hemodialysis. And he contrasted that with 365 patients with type 2 diabetes who had normal kidney function. And this study really is eye-opening. You can see along the top row, we have patients with end-stage kidney disease, contrasting glycated albumin and A1C. And on the bottom column, we have the controls without nephropathy. And I've got a red line drawn for the blood sugar of 200 milligrams per deciliter. And I just want you to see that if you look at the patients who don't have nephropathy, the hemoglobin A1C in these patients with a blood sugar of 200 was over 8%. But in the dialysis population with a blood sugar of 200, the hemoglobin A1C was approximately 6%, 2% lower for the same blood sugar in patients on dialysis, which was presumed to be from the effect of a shortened red cell survival. When they looked at glycated albumin in the non-nephropathy controls and the patients on dialysis, I think you can see the glycated albumin for a blood sugar of 200 was about 21% in those without nephropathy, 22% in those with nephropathy. So the GA was not impacted or hardly impacted, whereas the A1C was tremendously impacted. And the hemoglobin A1C was inversely correlated with the dose of erythropoietin for anemia in the dialysis patients. No effect of erythropoietin dosing on glycated albumin. This is the data from those patients. And I want you to see, if you use the hemoglobin A1C to gauge glycemic control in patients on dialysis, in this study, if you presume an A1C was less than 6%, 57% of patients looked like they had excellent glycemic control. 23.7 looked like they had good glycemic control based on A1C. So we're looking at 80% of patients on dialysis with an A1C appeared to have excellent glycemic control, only 7% poor glycemic control with an A1C over 8%. But these are falsely low values because of dialysis. And in fact, if you then look at GA and categorize the degree of glycemic control, you can see only 28% had excellent control and about 20% good control. Nowhere near the overestimate of good control with the falsely low hemoglobin A1C. And in fact, 36%, not 7%, 36% of those dialysis patients had poor control with a glycated albumin over 24%. So the danger of using an A1C in hemodialysis patients is it's approximately 2% lower in these patients from Japan, and it makes everybody look like their glycemic control is good when in fact it may not be. So having been struck by that data, we did a similar study in the North Carolina Wake Forest dialysis unit. So we published this in Kidney International in 2008. And I want to just take you through this study. It's very similar to what was seen in Japan. We had 258 patients with diabetes on dialysis, and we used 49 controls who had diabetes durations of about 12 years with no nephropathy. And the bottom line is the ambient serum glucose was statistically significantly higher in the dialysis patients. It was 172 milligrams per deciliter versus 146 in the patients with diabetes and no nephropathy, statistically higher in dialysis. Okay, well, we then looked at the glycated albumin. And the glycated albumin was statistically significantly higher in the patients on dialysis, just like the blood sugar, 18.7% compared to 15.3% with a p-value of 0.002. Very good. The glycated albumin tracked the blood sugars like we hoped it would, like it did in Japan. Well, here's the striking thing about our study. Here's the hemoglobin A1C. And although the blood sugars were higher and the glycated albumin was higher, the hemoglobin A1C was lower, only 6.8% in the high sugar dialysis population compared to 7.3% in the patients without nephropathy who had lower blood sugars. And it almost was statistically significant. P-value was 0.058 in the wrong direction, where the patients on dialysis looked like their hemoglobin A1Cs were better in spite of higher blood sugars and higher glycated albumin. We then did a plot of the relationship between the hemoglobin A1C and the glycated albumin compared to the glucose. And I want you to see the A1Cs in cases and controls are statistically significantly different. The slope of the curves was p less than 0.001. For glycated albumin, the curves are much closer together. They are not statistically significantly different. The p-value 0.19. We looked at the effect of the serum albumin on the glycated albumin in this population, and I think you can see the albumin concentration ranging from low albumins below 3 to higher albumins above 4, no effect on the GA percent. It was consistent. So the serum albumins did not really impact it in this hemodialysis population. And then we looked at what predicted the effects of hemoglobin A1C and GA in models of age, ethnicity, gender, duration, medicines, and we looked at dialysis status. And I think you can see that the presence of being on dialysis had a statistically significant effect on the hemoglobin A1C, whether you did a full model or a reduced model. Being on dialysis had no effect. The p-values were 0.7, and higher for glycated albumin. So dialysis status did not have a significant effect on the GA, whereas it did on hemoglobin A1C. And then finally, we looked at the effect of EPO dosing in hemoglobin on the hemoglobin A1C, and you can see that the higher the dose of EPO, meaning the more EPO resistant, the more severe the anemia, the actually lower the A1C, and that was contributing to the effect of these falsely low A1Cs based on sugars in the dialysis population. And as the hemoglobin fell, again, the A1Cs fell. So we didn't see that effect of EPO on glycated albumin. We followed up the dialysis study with a number of reports. Here's a summary of multiple papers from the American Journal of Nephrology in 2010. And we looked at people with severe kidney disease, GFRs below 15, all the way up to GFRs above 60. And I think you can see that in red, we have the relationship between the blood glucose and the A1C. It is not consistent. As the GFRs are higher, above 60, here's the relationship. But as the GFR falls and the hemoglobin A1Cs then also fall, the ratio of glucose to A1C rises. So there's a positive slope on this curve as the GFR falls, and the relationship between glucose to A1C changes when the GFRs get below 30 particularly. Here's the relationship of glucose to glycated albumin. It is nearly a straight line, whether we look at a GFR above 60 to patients on dialysis. There's very little fluctuation in this line, so the relationship of GA is not changed by the change in GFR from 60 down to below 15 on dialysis. So it's not just dialysis patients. And the concept is severe kidney disease impacts the hemoglobin A1C assay to a far greater extent than it impacted the glycated albumin assay. So the next question we asked is, does sugar control assessed by hemoglobin A1C impact survival in patients on dialysis? Does it impact hospitalizations? And there was reports from Mark Williams in Boston, looking at about 25,000 patients with ESRD at Fresenius, and he published a paper in 2006 and then a reanalysis in 2010 that said no, the hemoglobin A1C did not predict survival or hospitalizations in dialysis patients in 25,000 patients. There was another series of reports by Cam Kalantar-Zeta on the West Coast, where he looked at almost 24,000, followed by 55,000 patients at a large dialysis organization, published in 2007 and 2012. And he said, wait, the hemoglobin A1C does impact survival in patients on dialysis, but there's a big but. And the but is you have to adjust for more than 20 factors to see the effect. And I'm going to show you that actually the unadjusted A1C got the results completely backwards. And it looked like in unadjusted studies from these 55,000 patients, the higher the A1C, the longer people lived. That was from nutritional effects. Once you adjusted for these 20 plus factors, the higher the A1C, the lower the survival. But we don't have those 20 factors in our pockets to adjust for when we're making rounds in the dialysis unit. And then finally, Mark Williams looked at hospitalization rates in those 25,000 patients, and he found that only A1Cs less than 5% or greater than 11% were associated with hospitalizations, the extremes. And that extreme was only 14% of patients. So in 86% of patients, he felt the A1C did not predict hospitalization. Let me take you through the data from Dr. Cam Kalantar-Zeta, published in 2012 in 55,000 dialysis patients almost, a mix of African Americans, Hispanics, Caucasians, where he felt hemoglobin A1C did predict outcomes. And I'm going to show you the flaws in the logic of that study in my mind. Now, he analyzed the data several ways. First, he did an unadjusted model that just included the hemoglobin A1C and the time that it was done with mortality, much like the analyses we've all done. And this is an important analysis because this is what you get when you're seeing your patient in the clinic. You just get a hemoglobin A1C and you have to make a decision. But in addition to the unadjusted model, he did a case mix adjusted model that also included age, sex, race. It included dialysis vintage, how long the patient was on dialysis, insurance status, marital status, dose of dialysis by KP/V, residual kidney function, 8 more factors. And then he did finally a third model, which was case mix plus malnutrition inflammation complex, where he included 12 more factors of nutritional status and inflammation like BMI, normalized protein catabolic rate, and 10 laboratory measures such as total iron binding capacity, ferritin, phosphorus, calcium, bicarb, white count, 12 factors. So a total of 20 more factors were included in these more complex analyses. And that is what he based his results on. I'm going to tell you, you don't know the normalized protein catabolic rate, and you don't have data on insurance status, divorce, marital status, all these things. Well, here's the outcomes of his study. And in red is the unadjusted model, which is the data you get, a hemoglobin A1C. The higher the A1C, as it goes up, mortality fell. So this reflected nutrition. Bottom line is, the lowest A1Cs were associated with poor survival, higher A1Cs, better survival. But once he threw in those 20 factors and did the case mix malnutrition inflammation complex analysis, you see the opposite. You see that as that adjusted A1C went up, mortality went up. The opposite of what you see with just the unadjusted model. Here's the blood glucose. And I want you to see in his unadjusted model with blood glucose in red, as the blood glucose rose, mortality rose. That's what you should see with A1C if it was going to accurately reflect outcomes, when in fact it went the other way. And in the adjusted model, you can also see higher blood sugar associated with poor survival. So just to go back one more time, this is the problem with using the A1C in dialysis. We don't have the ability to adjust for 20 factors quickly. And here, once the A1C was above 8%, it looked like survival was better. We all know that 8, 9, 10, 11% A1Cs shouldn't improve outcomes. And this was their curve where they felt there was a sweet spot in dialysis between about 6 to 8 or 7 to 9, where they saw the best survival. And if you have low A1C or very high A1C, there was poorer outcomes on survival. after all that adjustment. This is the hospitalization data, from Mark Wilson, the 25,000 patients where you can see an A1C less than 5% or greater than 11% predicted hospitalization rates, but the 86% of values in the middle did not. So I think there's tremendous flaws with using A1C in hemodialysis and peritoneal dialysis. It is markedly lower than it should be because of shortened red cell survival. It's impacted by anemia and erythropoietin dosing, and it is not predictive of outcomes, and none of us have the ability to rapidly adjust for 20 factors. What about the glycated albumin? Does that predict patient survival and hospitalization? Well, at the very beginning, I showed you that recent meta-analysis in almost 26,000 dialysis patients, and I showed you there was a study from us. This is the data from that study that we published in Clinical Journal of the American Society of Nephrology in 2011. We looked at 444 patients on hemodialysis with diabetes across the Wake Forest dialysis program. And every 3 months, we got a glycated albumin, and we followed these patients for about 2 3/4 years. We also took every blood sugar and every hemoglobin A1C ordered by the treating physician, and we followed them longitudinally over time. So the initial enrollment was January 1st, 2007 to June 30th, 2007. Follow-up had a max 2 3/4 year follow-up, and we stopped following them in late 2009. We had 3,041 glycated albumin measures. We had 1,743 A1C measures reflecting standard of care as ordered by the doctor. And we prospectively measured death and hospitalization. We censored the patient if they got a kidney transplant or transferred out. And we reported 56 deaths in those 444 patients in the next 2 3/4 years. And this is the p-value and the hazard ratio for the effect of glycated albumin on survival. And I think if you look at the model where we add demographics in, so we added age, sex, and race, you can see the p-value for glycated albumin predicting survival is 0.02. The hazard ratio is 1.14. We added in comorbidities. We added in such as peripheral vascular disease, cardiovascular disease, things like that. We added in hemoglobin, phosphorus, and albumin levels. Those are important in patients on dialysis. And we came up with a best fit model. And you see the glycated albumin p-value is 0.03, hazard ratio 1.14. The higher the GA, the higher the risk of death in the best fit model. And the other factors in that model were older patient age, peripheral vascular disease, hemoglobin, and albumin, all well-established predictors of survival. So in this multivariable model, once you account for vascular disease, albumin, hemoglobin, and all that, GA has an additive effect on survival. It's remained significant. Let's look at the hemoglobin A1C. Hemoglobin A1C, actually, in the demographic adjusted model is not significant. P-value is 0.22. In the unadjusted model, looking at it alone, it is significant, just like you saw in the other study. The higher the A1C, the better the survival, which is not intuitively what we'd expect. The higher the glycated albumin, the poorer the survival. So hemoglobin A1C should go in the same direction. But when you add comorbidities, when you adjust for hemoglobin, phosphorus, and albumin, you see the p-value is no longer significant. Hemoglobin A1C in this prospective study over time did not predict survival in these patients. And in the best fit model, it is missing. It was not a predictor, whereas age, BMI, peripheral vascular disease, and albumin remain. So the GA was a statistically significant predictor in the best fit model for survival. Hemoglobin A1C was not. We looked at proportion of individuals who were hospitalized in this prospective study over 2 3/4 years. And in the quintiles of A1C from lowest to highest, you see there's no consistent relationship. These were glucose values, again, really not a great relationship. In the glycated albumin, hospitalizations over the next 17 days from a reading beautifully correlated in stepwise fashion with rising glycated albumin from lowest quintile to highest quintile. So glycated albumin in dialysis actually predicted hospitalization. And we looked at the effect on cardiovascular hospitalizations and length of stay. And in another paper that we published, only the glycated albumin predict those outcomes. Hemoglobin A1C did not. So I think that there's a wealth of data out there on effects of hemoglobin A1C in dialysis and glycated albumin in dialysis. And we participated in an earlier meta-analysis. We worked with, Dr. Kalantar-Zeta and the doctors that were on those large reports. And there was a suggestion in this study that a hemoglobin A1C over 8.5% in dialysis patients predicted survival and outcomes. I would just tell you, in my mind, if you get a hemoglobin A1C of 8.5% in a dialysis patient, for that same degree of blood sugar, in my mind, the A1C is really 1.5 to 2% higher in patients without kidney disease. So it would equate really to about 10 or 10.5% in a non-dialysis population. Other caveats that I'll just mention is there may be a role for continuous glucose monitoring in dialysis. It's a little more complicated to do than GAs. Dr. Galindo will focus on that. And remember, there can be falsely elevated blood glucose with glucose dehydrogenase, pyroquinolone, quinine-based glucometers in peritoneal dialysis patients if they use the icodextrin dialysate. Maltose and maltotriose are degraded from icodextrin by amylase. These can be falsely read as glucose and give you a falsely elevated reading if you use this particular glucometer in a peritoneal dialysis patient on icodextrin. If they're not on icodextrin dialysis, if they're on dextrose dialysate, it's not a problem. But if you over vigorously treat, you can cause severe hypoglycemia. So that's just something to bear in mind. So to wrap up, given similar glycemic control, the hemoglobin A1C is markedly lower in patients with end-stage kidney disease, and it does not accurately reflect recent glycemic control compared to patients who are not on dialysis. The glycated albumin assay is far less impacted by end-stage kidney disease. A higher unadjusted hemoglobin A1C in pretty much all large studies associates with improved survival in dialysis, which makes little sense unless you realize the fact that it's a marker of improved nutrition. An adjusted hemoglobin A1C, which by the way took 20 covariates that are not covariates we have readily available to us, then is associated with poorer survival in dialysis. It's just that we don't have access to those adjustments on a quick scale. So the unadjusted A1C is what you get, and you have to make a decision based on. The glycated albumin accurately predicted patient survival and rates of hospitalization in end-stage kidney disease with minimal or no adjustment, and we showed this in a prospective longitudinal follow-up study in a large dialysis program. And in the meta-analysis, a hemoglobin A1C over 8.5% was associated with an increased risk of death. So I'm going to stop there. I want to thank everybody for inviting me to participate in the seminar series, and I'll be happy to take any questions you may have.